Hello, my name is Jeff Kuvan. I'm the chair of cardiology at Northwell Health, and I'm a trustee of the American College of Cardiology. And it's a pleasure to spend a few minutes with you today talking about uniting to build a new board of cardiovascular medicine. And I must say, this is an exciting time for cardiology to think about the concepts of a new board. I'd like to share with you some of those ideas. I think we'll all agree that cardiology continues to lead the way in evidence-based care, in clinical competency statements and clinical registries, how we implement new technologies and therapeutics, and how we have really redesigned the team-based multidisciplinary approach to patient care. Now indeed is the right time. In fact, it's a perfect time for us to come together to develop new methodologies to demonstrate how we can show our competency through a novel program of continuous certification. Although this will require innovation, technology, and of course resources, cardiologists and our patients clearly deserve this and will benefit from this. The House of Cardiology is up to the task. So because of all of these points, on September 21st of this year, a coalition of cardiovascular societies, including the American College of Cardiology, the Heart Failure Society of America, the Heart Rhythm Society, and the Society for Cardiovascular Angiography and Interventions, came together to announce the intent to submit an application to the American Board of Medical Specialties to form the American Board of Cardiovascular Medicine. Other organizations, including the American Heart Association, have collaborated with these groups to develop this application, and we're hopeful that formal support by the AHA and others will be forthcoming. Hopefully you all saw the announcement. It's time for a board of our own. This has been posted not only by the ACC, but the other societies as well, which really clearly states the idea behind building a new board and some of the nuts and bolts of what we think the application and ultimately the board will provide. So what I'd like to do in the next few minutes is talk a little bit about why is now an important time to consider a new board, some general concepts of what a new board would look like, and then some next steps. So first, why now? Well, let's discuss what are we doing now? What is the present state for cardiologists, both from the initial certification standpoint as well as maintenance of certification. So right now, initial certification is that the fellows complete their training either in general cardiology or in one of 4 different areas of particular interest: interventional, electrophysiology, heart failure, or adult congenital heart disease. At the conclusion of their ACGME training, they sit for a closed book, secure, multiple choice examination, which has a certain pass rate. And our fellows ultimately, hopefully, pass that and then become certified by the American Board of Internal Medicine. Continuous certification or maintenance of certification, there are presently 3 approaches. The 10-year examination, which the diplomat sits for, typically 1 or perhaps 2 examinations at the conclusion of 10 years. It's a closed book, secure examination. And just to note that this examination will likely go away in the near future, as the concept of 10-year examinations will soon move away. Other options include the collaborative maintenance pathway, which is a collaboration between the ABIM, the American College of Cardiology, and societies, in which the diplomat is involved in both learning as well as testing, typically on a 5-year rotational basis, with testing each year in the areas of cardiovascular disease, interventional cardiology, electrophysiology, and heart failure. Soon, adult congenital heart disease will have a CMP pathway as well. And then finally, a few years ago, the American Board of Internal Medicine established their longitudinal knowledge assessment, which is more about answering questions in real time during the course of one's days or one's weeks in cardiovascular disease and interventional cardiology. The concept with all of these types of examinations is question-based, high-stakes examination, and a cut point of passing or failing. And I think this is what we want to potentially consider changing, is this concept of high-stakes examination with a threshold of either you're in or you're out. So why now? Well, that's one reason, is that I think that we have all moved away from, certainly in the continuous certification space, of this concept of being time tested and having to sit for an examination that has very high stakes. Other reasons why now is that I think we would all agree that cardiology has evolved into a massive, distinct specialty, different from internal medicine. We all believe that internal medicine has been the foundation for cardiovascular disease and training and our clinical practice, but it clearly has distinguished itself as a distinct specialty with now many subspecialties, certainly dedicated training paradigms, competency statements, guidelines, you name it, cardiology has really established itself. Second reason why now is that cardiologists have been asking for this for many, many years. This has been the source of many a discussion in boardrooms, in the hallways, on the wards. Why is this process onerous, burdensome, costly? The next reason why now is that the concept of grandparents, grandmothers or grandfathers that have not necessarily had to participate in maintenance of certification up to this point will soon end. The American Board of Medical Specialties and the ABIM have now mandated that in 2024, grandparents now need to show that they indeed are participating in maintenance of certification. So we need new pathways, we need new paradigms. We need to make this more seamless and integrated into our clinical practice. And then finally, I'm sure everybody has read on Twitter or listened to conversations or been part of conversations about what is the future of MOC. It's been under significant scrutiny. Is this the right way to make sure that we indeed are competent as clinical cardiologists? And maybe there are better ways to assess competency. Another reason why now is the world of certification continues to change. Now, just to make sure everyone understands, in the United States, the main certifying body that is recognized by payers, by hospitals, by systems is the American Medical Association. The American Board of Medical Specialties is an organization that sits within or under the AMA. The ABMS has 24 boards, of which the American Board of Internal Medicine is one and happens to be the largest. And cardiovascular disease represents the largest specialty within the ABIM. The ABIM itself is also undergoing exploration in terms of what next, how better can we as a community of physicians assess ourselves and show that indeed we have competencies to continue in clinical care. So this is an important concept, and you'll hear why we think that now is a great time to partner with the ABMS, the only recognized certifying organization in the United States, to think about paradigms in initial certification and continuous certification, and to see if this is the right time for a new board of cardiovascular medicine. The ABMS has published their new standards for all of their boards, which would include standards for a new cardiovascular board, which go into effect in January 2024. These standards recognize that it's not so much about passing a test, it's more about the holistic approach to clinical care that is of utmost importance, and how we continue to educate ourselves and how we understand what we know, but also what we don't know. So some concepts for a new cardiovascular board. On the left is the paradigm of training. As cardiologists, we initially get certified after internal medicine with the ABIM examination in medicine, and then after cardiovascular training with an ABIM certification in cardiovascular disease, and perhaps one of the specialty areas as mentioned. And then we have a lifelong journey of learning, assessing, and showing that we indeed are competent. The concept for a new board would suggest that we all believe that indeed learning doesn't end at the end of fellowship, that we all have a public responsibility to our patients to make sure that we are competent, that we're providing the right level of care to the right patients. We need to continue to make competency-based education patient-centered. It's all about our ability as cardiologists to take the best possible care of patients. We need to make sure it's competency-based, it's ability-based. It's not based on one's ability to pass a test. It's based on one's ability to understand knowledge and then implement their knowledge at the bedside. Of course, it involves continuous learning, not so much continuous testing. This should be a supportive, not a punitive process. And of course, it should be specific to one's practice. It needs to be focused on what the clinician is doing at the bedside. So these concepts for a new board are basically what are going to make up the board application for a new cardiovascular medicine board to the ABMS. You can see there are 7 bullet points here. First, we have to, in an application form, make the case. Why is now the right time? What does the House of Cardiology think about a new board, and how are we coming together to really formulate the concepts for cardiovascular professionals moving forward in a competency-based fashion? The next concept for a new board is, how does the board interact with societies? Should there be interaction, and how can we make that happen? With the American College of Cardiology, with heart failure, with SCAI, with HRS and other societies. We think that there should be a lot of discussion between the board, an independent board, and our societies, as our societies really know what our clinicians need, what their knowledge gaps are, and how to fill those gaps best. What does certification and continuous certification look like in a new board? And I'll explain that in the next few slides. What is the diplomat going to experience? How technology can integrate into the diplomat experience? How the diplomat will be evaluated over the course of time? How this new board, this independent board, would be governed? And finally, what are the finances behind it? How much will it cost to stand up a new board? And how will our diplomats be faced in terms of cost challenges? So let's start off with initial certification. And remember, this is under the guidelines of the American Board of Medical Specialties. And the long story short is initial certification initially at the onset of a new board will look very similar, whether it's in general cardiology or one of the specialties, to the existing examination. There will be, and the ABMS does require, a secure timed examination for trainees upon completion of their training program to sit for a test. This, of course, is based on a blueprint of materials that one is expected to know for their clinical practice. And this is where I think the societies could play a significant role in redeveloping the blueprint for this examination. Of course, there would be general cardiology as well as the existing subspecialty examinations, but a lot of opportunities in the future for innovation in this space, to bring in different testing methods, to bring in more types of specialty examinations. And of course, this would be ABMS and AMA certified. So the look and the feel of this initial certification would be very similar to what we're experiencing now, but with the opportunity to innovate and build upon a platform for the future. Now, you're going to see major changes now as we move from initial certification to the concept of continuous certification, not maintenance of certification, continuous assessment and proving that indeed we are competent and to be certified along the way. And this is the main concept that's important to think about moving towards a new board. The traditional approach, the present state, whether it's taking an examination in a testing center, whether it's doing the CMP or whether it's doing the LKA, these are high stakes questions. You get a score, you've either passed or you failed, and it doesn't really support the learner. What didn't you know, and how could you improve those knowledge gaps? The concept of continuous certification in a new board is really to assess what you know, but importantly, to acknowledge what you don't know, to then fill those knowledge gaps with activities that you're already doing, attending CME, taking courses, doing anything to fill those gaps, documenting it, of course, with technology, demonstrating that now you know those concepts, and then moving on. This, I think, is a fundamental difference and what is, I think, the most exciting about a concept for continuous certification in the new board. So in this new concept, it could be as simple as 1, 2, 3 for continuous certification. Certainly, to continue as a diplomat in cardiovascular disease, you have to maintain your licensure, you have to maintain your credentials at your local hospitals, healthcare systems, etc. But of course, the big bucket is you have to continue to be engaged in the lifelong learning process. And one way to do that is to understand what you know and what you don't know, perhaps to take a battery of low stakes questions, get a score and get feedback about what you don't know, be linked to opportunities to fill those gaps with CME activities or other ways to target what you don't know so you can learn or relearn. Make sure that that knowledge gap is closed. Make sure you're accumulating the right number of credits and then move on in a low stakes, low pressure environment. The ABMS and the new guidelines also understands, I think we all recognize the importance of quality improvement and performance improvement. And certainly there will be a way to attest that indeed you are participating in practice improvement. We all participate in practice improvement, whether it's contributing to NCDR or local QI initiatives in our practice or in our hospitals. This should be straightforward, but of course we need to attest to it and acknowledge that this is part of our lifelong learning journey. We would suggest that this new board would provide the tracking, the independent tracking and reporting of the diplomat as they move through these 3 tasks. The societies have great opportunities to help the diplomat understand the knowledge gap and then of course fill in the knowledge gap and be a supportive learning partner. So for continuous certification in the new American Board of Cardiovascular Medicine, this would no longer require secured, high-pressure, timed questions, but rather a leisurely way of understanding what you know and what you don't know, with supportive learning, the ability to close your knowledge gaps. There would be an assessment strategy which is formative, not summative. You would get continuous updates from the board about your progress. It does allow for remediation. Of course, it's linked to your daily activities of CME with great collaboration from our societies. And importantly, this would be recognized by your hospital, by payers, because it would be ABMS and AMA certified. In doing analyses of this new concept of a board, we estimate significant cost savings moving forward. So what are the next steps in the next couple of weeks to months? First of all, no change for what you're doing right now to continue your certification pathway. So if you're one that wants to sit for the 10-year examination, there might be another opportunity or 2, but again, that's likely going to go away regardless. If you're participating in the ACC CNP collaborative pathway with the ABIM, that will not change for the foreseeable future, nor will the LKA. So right now, hold on, don't change your plans for the next year or so. But if a new board is granted, there should be seamless transition from the ABIM to a new cardiovascular medicine board. Why? Because both would be under the same umbrella of the American Board of Medical Specialties. The ABMS allows for only one board to provide certificates to a specialty. So the cardiovascular specialty would move from the ABIM to the new board. And we anticipate seamless transition. In the meantime, as we submit the application to the ABMS, this will take time. This will take 6 to 8 months to allow the ABMS to adjudicate this, to make a decision. Hopefully by springtime, we will know a little bit more. We will continue to have discussions with our society partners and many other partners across the House of Cardiology to really build a cardiovascular medicine board. If you'd like more information, you can go to cvboard.org, where we have links, webinars, a recently recorded heart-to-heart with President Hadley Wilson, some videos, and frequently asked questions that should be helpful as well. In closing, a few key points. Cardiologists and the House of Cardiology has been waiting for this for a very long time. Now is the time to consider this, and I think the window of opportunity to move this forward is indeed now. Remember, the American Board of Cardiovascular Medicine, if granted, will be an independent board, independent of societies, independent of individual cardiologists. And this is important for us moving forward, that an independent board really set the standards for cardiology to move forward. We anticipate, if granted a new board, there be seamless transition under the American Board of Medical Specialties. We won't lose certification. We won't lose the ability to practice cardiology within our areas of interest. Payers will not have questions, etc. We anticipate the whole process to be much less burdensome, less costly, more supportive, less punitive, and more aligned with what we want and what we need as practicing cardiologists. This will absolutely be an iterative process. It already has been an iterative process. We've been working on this for now a few years. It looks different than what we first anticipated it looking like and will likely continue to change. And that's what's exciting about this. Initially, we anticipate the board looking fairly similar in terms of 5 certificates like we have right now with the ABIM, but there's so many opportunities to grow and innovate beyond this. So look for new ways, look for new ideas, new concepts, and pathways that we can think about and get excited about. So the long and the short of it is, this is exciting. Stay tuned. We hope to give you answers in a very short period of time. We'll see you next time. Thank you.